Good afternoon or good morning, everyone who has joined us today for our Population Health Management Market Trends webinar. Thank you for joining us, and we're really looking forward to sharing some of the insights that we gleaned during the process of this research around where the PHM market is today and where it is headed. You can download the slides directly from the handout section of the GoToWebinar control panel. And feel free to submit questions throughout the course of the webinar, which we will address at the end of all of the different slides. So first, I want to reiterate what our core beliefs are here at Chilmark Research and what drives the research that we do throughout the course of a year. Our team is united by the belief that effective deployment and use of IT is essential to modernizing care delivery and ultimately improving the patient journey. We monitor the trends and developments in the industry with a focus on those technologies that will be transformational to the way that healthcare is actually being delivered. We provide comprehensive, objective, high-quality research for busy executives. It's our way to help create a more informed, future-ready market of products and customers. Work with us today to be ready for tomorrow. And now a quick introduction to your three presenters today. We are joined by Brian Murphy, who is our Senior Analyst for Interoperability. He also helps cover the analytics and PHM spaces that, of our domains of coverage. He is joined today by Matthew Golden, who is a Senior Analyst covering care management, and Brian Eastwood, who's an analyst on our team covering engagement. So without further ado, I will let Brian take over.
Hi, and thank you very much, John, for that kind introduction. So today, basically, we're going to be talking about population health management as it stands now in 2018. This webinar is based pretty substantially on a market trends report that we released some 3 weeks ago during HIMSS. And that report has been in gestation for a couple of years. The information base that we kind of worked off of to develop this report pretty much consists of our conversations with provider organizations who are trying to put together population health management programs, as well as some 40 plus 42, 43 different vendors that have put together population health management products and solutions. And this report was really kind of a roll-up of the sum total of all that knowledge. So the three of us, myself, Matt Golden, and Brian Eastwood, kind of put our heads together to write and publish this report. But this is essentially what we're going to kind of run through today. Our definition of population health management, and I can tell you, and I think most people would agree that that the term is used in a lot of different contexts. It means kind of different things to different people, but we've tried to kind of define it here for the purposes of this report. We're going to talk about why it's still important, why it's important today. Primarily, this is going to be about who buys PHM solutions, who makes PHM solutions, the technology that goes into them. And at the very end, we will, hopefully we will have given you some information to take away and use in kind of your day-to-day activities. This slide kind of gives you at the top our definition of population health management. And essentially, it's the idea that a group of organizations kind of get together and the providers sort of adjust their perspective a little bit from the kind of traditional way that they've worked. Obviously, they need to focus on the health and well-being of the patient in front of them, but there is this idea that entire cohorts of patients who are similarly situated can be managed kind of as a group, and that this might actually deliver better healthcare to the individuals as well. All kind of population health management programs involve establishing some kind of a contract that aligns the interests and the goals of the different organizations involved in delivering care, and that includes, providers, payers. It could include employers nowadays, as well as a bunch of other different kind of community-based organizations. The third element of this definition is that there may be organizations that are not participating in these contracts, and the success or failure of a PHM program can depend on these. So there's this real emphasis on interorganizational kind of information flow and cooperation. The bottom line is that any population health management type program is going to be a team effort, which is something that has historically been kind of an unnatural act for in healthcare. When a healthcare organization decides to embark on some kind of population health management program, these are essentially kind of the three chunks of things that they have sort of looked at. The first is establishing some kind of a strategy, some way for them to justify doing population health management from a business standpoint. The second is trying to figure out how this is going to impact them financially. Are the revenues going to be there? Will it impact other revenue sources? Things of that nature. The third, and I guess arguably the most important, is the enabling technology. And the PHM Market Trends Report that this webinar is based on focuses very heavily on this technology piece. But it is important to recognize that these other two elements, the overall strategy and a financial plan, are foundational to being able to pull these kinds of programs off successfully. This is kind of what PHM looks like in practice. This is, when you look at how healthcare organizations operationalize PHM programs, it's usually this kind of circular set of ideas. They decide they're going to go ahead and do it. They put together the contracts with payers and any other kind of resource that they think they need to conduct the program. They take a look at their patient populations and figure out which cohorts within their overall catchment area would yield the best possible result. They're able then to hopefully negotiate and set reasonable clinical and financial goals. Then they need to figure out what kinds of clinical and administrative interventions they need to put in place in order to achieve the goals of the PHM program. And this involves obviously defining KPIs, whether they have to do with cost or quality or utilization or what have you. It's and then they need to measure the results and then make whatever adjustments are required to basically do better. Why is PHM still important? This term has been bandied about for quite some time. And I think most people are aware that the last year or two, there's been a certain level of turmoil in healthcare. But I think one thing is fairly plain, and that is that the cost curve is not going to unbend itself. When people talk about population health management, the association with value-based healthcare is absolutely unavoidable. And if there is some other plan for bending the cost curve, besides value-based healthcare, value-based payment, value-based care. It's, I haven't heard it. So VBR is not going away. And despite all of the uncertainty coming out of Washington over the last year or so, it does seem like things are settling down somewhat. The newest, the person in charge of HHS has signaled unambiguously their support for continuing on the, on this path from volume to value. Private payers are, they have their level of interest in this hasn't really abated despite what's happened with the public payers. Private payers are continuing to experiment, and as we'll see in a couple of minutes, we're seeing more and more participation from them in terms of buying the kinds of products that we're going to be talking about here in a little bit. Population health management is actually being taught in med schools as something that affects the standard of care. In terms of the inhibitors, I mean, it is still, like it or not, it's still a fee-for-service world, and that, there's a certain level of comfort and certainty that gives to large parts of the healthcare system in terms of predictable revenues. So, there's a certain kind of built-in inertia there. The HCOs are reluctant to spend on things that don't have some kind of ROI, and in particular, the smaller healthcare organizations are going to be looking for short-term, or in some cases even immediate ROI for any kind of investment that they might make in something like population health management. The technology of pulling off this kind of program it's not easy. Integrating the data, integrating the functionality is very difficult, very time-consuming, and very resource-intensive. Most IT organizations anywhere in healthcare have got lots of other priorities. The simple business of maintaining patient flow, making sure that the bills go out on time is something that they can't turn away from, obviously. And there's also the prospect of new and disruptive entrants from outside of healthcare. I'm not sure how much of a threat this is, but people are certainly talking about things like the Amazon, JP Morgan type deal, and the possibility that they're going to somehow change the way healthcare is done. So one of the things we looked at, one of the things we tried to kind of sort through here is trying to figure out certain identifiable submarkets within population health management. Up till now, we've got three here that we've defined. They're called captive ambulatory, independent ambulatory, and payer provider, and I'll talk about them in turn. Most of the activity over the last, say, 4 or 5 years has been driven from or emanating from hospitals, primarily because they have they're able to they've got money to experiment, and the population health management programs are seen as kind of one element in a fairly broad service portfolio. Now, there's only a certain number of hospitals in the country. If you look at the ambulatory networks that exist, the sort of pure independent physician-owned practices, numerically, that represents a much bigger addressable market, but has until now really been dwarfed by hospital-led efforts. One of the things we are beginning to see is the emergence of truly independent efforts that are not necessarily owned by hospital, not necessarily owned by physicians, and that have some level of payer participation or even ownership in some cases. So this would be community-based organizations. It would be health information exchange organizations. But the bulk of the market to date has been in this captive ambulatory column. We think independent ambulatory is in a position to grow pretty significantly, and we're keeping our eye on this payer provider category. As I said, we talked to 42, 43 different companies, and amazingly, every single one of them describes their PHM product set using 4 different technology domains. And they consist of these that you see right here on the screen: data aggregation, analytics, care management, and patient engagement. And we're going to talk about each of these in turn. I'm going to talk about data aggregation and analytics. I'm going to turn it over to Matt, who will talk about care management, and he's going to turn it over to Brian Eastwood, who will talk about patient engagement. But just by way of preview here, we're going to talk a little bit about kind of how we see the state of the market and what kind of the challenges and opportunities are in each of these 4 domains. Before I get into that specifically, I just wanted to give you a sense of where we think these different domains are in terms of their overall maturity. And I will say that the most mature, even though it's probably got a ways to go, is analytics. Data aggregation, sort of there. Care management is really just kind of beginning to start out. And patient engagement is probably arguably the least mature, and the technology area that probably could deliver the most benefit in the end. So data aggregation. The data has always been a problem in healthcare, and data aggregation in PHM is unfortunately more of a artisanal process than an automated process. Right now, we think that the ability to kind of put together EHR and claims data is table stakes, and of all the vendors we talk to, pretty much all of them can do it. But as I intimated, doing it for one customer doesn't necessarily mean you're going to be able to do it as cleanly or as well in another customer, because the combination of EHRs and claims is different. So it's got to be done kind of one-off on a customer by basis. There's a tremendous upsurge in interest in the so-called social determinants of health, and I think that term is probably not super well understood at this point, but a lot of folks are beginning to think that it's information from those kinds of sources that are going to be more indicative of not only status, but could also be more helpful in terms of, it's sort of a leading indicator as compared to kind of raw EHR data. There's also a corresponding increase in the number and variety of different organizations that want to contribute to this data store for population health management. And there's also a lot of new organizations that want to get access to it. The most recent thing I think that's happening across the industry that is, well, at this point, I got to say it's creating concern necessarily more than the ONC is pushing this idea of something called flat FIRE or population level query, and this would be the ability for a single program or a single user to issue a query that goes out potentially to the whole country and returns data, all the relevant data that might exist on a population as opposed to a individual patient. So there's There's a range of kind of privacy and security concerns, performance concerns, liability concerns about how this could or might work if it ever becomes a reality. There's concerns about the timetable that ONC has put forth on this. I mean, something like this would represent a, real sort of, there's no question. It'd be lots and lots of uses for something like this, but how it's going to be implemented is still very much up in the air. Most of the vendors that we've talked to put together this report are kind of pushing the idea of a data platform. It's essentially, they are trying to make this less artisanal and more automated. But there's all kinds of networks and data types and transaction types that are out of scope of the data capabilities that most of these vendors provide. So I think we're a ways away from anybody really putting together a true kind of data platform. And the old, bugbears in healthcare, consent management, patient matching, semantic standardization continue to be very difficult challenges and contributes to this problem of every single customer being a one-off. On the analytics front, this slide kind of describes the different kinds of analytics that you find in these products. And it describes sort of where we are in terms of specific capabilities within each of those categories. The items that are shown there in blue are, for the most part, kind of there. These products do a reasonable job of providing the level of functionality that's indicated there. The items that are indicated there in red are things that they're less advanced on and represent kind of opportunity areas going forward. Kind of the bottom line on analytics in a lot of these applications is that the most common application is a reporting application. So there's lots of quality and gaps reports. There's lots of cost and utilization reports. There's lots of risk reports. And the overall opportunity here is to move a little bit more, a little bit beyond this idea of simple reporting and incorporating the output of these analytics more deeply into existing kind of line of business applications. The other opportunity is what we've indicated up here at the top. Most of these reporting applications kind of describe what's happened, and we're beginning to see some genuine movement in terms of the vendor's ability to make specific or even general predictions about what might happen. So with that, I'm going to turn it over to Matt. Are you there?
I am. Thanks, Brian. Appreciate that, and appreciate the overview. Just going to talk briefly about the care management related aspects of the report and some of the key differences we found, as well as some of the key areas of focus moving ahead forward for the vendors in the report. We definitely did find some common areas of alignment by vendors around basically trying to structure a care plan that's centered and focused on an individual patient and or member, depending upon the terminology that's used by the buyer of the solution. So in terms of looking at this, where we saw alignment among the vendors, we saw them with the ability to identify and assign patients to various types of programs that are in place. We saw the ability to create a care plan with some of the standard elements of a care plan with goals, tasks, interventions. We saw about communicating care plan to the info through either a portal-based solution or a mobile-enabled app to the care plan and have access to the care plan. We saw about the ability to monitor patient progress towards goals within the care plan itself. And then we saw a lot of manual updating of these care plans by the care teams, predominantly usually a nurse care manager, but also several other individuals who may be a member of the patient's care team and have access to their care plan. Where we see more levels of differentiation among vendors right now really are kind of how patients are identified and assigned to programs. So not really only what type of risk methodology is being used, but what other types of criteria and information are being applied to those risk methodologies to identify those patients, and then how those patients are being assigned. Is this something that's done by manual queuing or manual queries? Is something that's done by automated business decision rules? We're seeing a lot of variation in the marketplace right now around that. Another area of differentiation is care plan content and workflow. This is the idea of, is the particular organization using third-party content from a vendor to pre-populate the information within their care plans, including the assessments and the actual care plan content itself, and then the actual workflow itself. Once you start to get beyond the basic structure of goals, tasks, and interventions, we're starting to see a little bit of differentiation in the marketplace, including about how and when individual tasks and interventions are being tracked. Care teams communicating with patients. Brian Eastwood will go into this a little bit more, but again, we still see a lot of variation in the marketplace, although it's still a relatively nascent functionality area. The last two areas are around care plan administration automation, which talks about the ability of these solutions to kind of automate some of the updating so there's not as much manual data entry into the solution. And then lastly, self-management by patients and caregivers. This is important, especially as these programs are being queued up by providers to cover more patients, especially maybe single chronic disease population patients, or even potentially wellness uses on a provider's use case. The self-management component of these solutions is going to be increasingly important to cover as more patients are enrolled in these programs. Next slide, please. So just wanted to talk about some of the future areas of care management development that we saw about both from an importance and an activity level. So again, there's many more use case or differentiation areas where we're seeing from a functionality standpoint. I just highlighted some of the important ones at a high level that we talked about. One area that came up was prior authorization integration in terms of the amount of services that are increasingly covered by prior authorization services and creating a better workflow process from this. There was a recent survey out from JAMA that reflected continued physician difficulty with this, and the ability to have timely and functional access to these services is to ensure that they have the appropriate authorization. Still mainly a manual workaround process outside of any of the solutions that we've seen, faxing, going to a payer portal, some cases even a paper handoff or a paper submission in some cases. That needs to be addressed and fixed. Other areas we're seeing key areas of importance, the ability about coaching, increasing health coaching services, whether this is provided through telemedicine or telehealth, other types of mean as these programs begin to include more wellness or wellness type features, or adopt some of the traditional payer-led disease management centered focuses, remote patient monitoring, now that telehealth and some of the codes have been issued by CMS starting as of January 1st this year for some select use cases moving ahead forward. So gradually starting to integrate that data types as there's payment to support those for providers. And then lastly, just the rules-driven workflow. This again goes back to the idea of trying to essentially ensure that these solutions can cover more patients without having to do manual data entry, and or can provide appropriate notification to care team members when there is an action at a timely and a timely manner to basically alert them instead of just dumping in everything into a work queue and assigning a work queue which cannot be covered in a standard day by a nurse care manager. So just wanted to talk about those activity areas. Where we're seeing the most, again, is I'd say around the care plan task assignment. Basically, how do you really essentially assign the resources within the care plan and queue the care plan activities and tasking queues, and then really around some of the other data use cases, bringing in additional data types, as Brian mentioned, especially some of the remote patient monitoring data, and then also starting to explore telehealth and telemedicine use cases around the health coaching services piece. Now I'm going to hand it over to Brian Eastwood to talk about patient engagement.
Thank you, Matt, and thank you, Brian. So I will be chatting a little bit about what we have discovered about the patient engagement process in researching our population health management report, as well as a forthcoming report that I have done on patient relationship management. A lot of vendors in the PHM market really present this very idealized patient journey where care teams have a complete view of the patient and are able to provide collaboration and support, not just for that patient, but also any caregivers or surrogates that they might have, in a multi-channel, multi-device methodology that allows for customized care plans and a very deep engagement process where they are contributing their own outcomes and data from the devices that they are using or applications that they're using. And then all of that information contributed by the patient is used to measure progress toward care plan goals and modify care plan goals as necessary. However, as you'll see on the next slide, the reality of the patient journey is a little bit different. A lot of the engagement solutions that are in use today typically consist of legacy type portals or point solutions. These are tied to single care episodes, single delivery systems, single conditions, and they end up providing a fragmented experience that, particularly once patients have left a healthcare facility, once they're outside the four walls and are on their own trying to manage the condition that they have. The same is true for educational resources, which tend to be limited to a single episode, to prevent a 30-day readmission, and they don't necessarily focus on the bigger picture of health and wellness for a patient, particularly one with multiple chronic conditions. And finally, a lot of these solutions don't really tie what patients are doing within them to larger business objectives and overall goals for patient engagement and improving the patient experience, which is a key point of population health management under value-based care. Additionally, we see some unmet needs with these solutions that providers are using through their PHM solutions for engagement. As noted before, outside the outpatient experience in the post-acute space, there really isn't a great way for an engagement solution, to connect with payers, employers, other providers such as specialists or other stakeholders who want to know what's happening to a patient and how that patient is progressing toward a care plan. Solutions are struggling to adopt to payer-provider convergence business lines and the need for data to flow among these entities to reduce the friction between them about what services are being provided, who is paying for them, and what the ultimate outcomes of those programs are. As noted, patient progress is a little bit difficult to see within these solutions, both on the patient side, but also on the clinical side. And it's also difficult to meet some of those care barriers or social determinants of health, as noted before, though a number of vendors are looking to try and identify them within their solutions. But the next step is really taking those and bringing them to a level where both caregivers, clinical care teams and patients can see that. And ultimately, the challenge that a lot of these solutions face is in being able to catalyze behavior change among patients, whether it's getting them to stop doing something that they shouldn't be doing, to start doing something that they should be doing, to continue doing something that they have started to do. And a lot of this through behavior science has been demonstrated to be accomplished best through short and frequent interactions with an application or a device several times a day in short bursts. And a lot of today's engagement technology isn't yet ready to support those types of interventions, and results in these very sort of stagnant and fragmented engagement experiences. And with that, I'll turn things back over to Brian Murphy to discuss the remainder of the report and what we discovered.
Thank you, Brian. And I'll go off script and just apologize to everybody for having so many Brians. If it's any consolation, we actually have a third Brian, and we're trying to figure out a way to get him on our next webinar, all three of us. So let's talk for a second about the actual vendors that we talked to, who kind of make up, whose products, solutions, and services make up the bulk of this report. Generally, they kind of fall into two categories of vendors who have historically sold products to payers and vendors who have historically sold products to providers. The provider-oriented vendors generally are coming out of the P4P world. Obviously a lot of, your PHM programs kind of built on past P4P efforts, things like PQRS, and hence the sort of singular focus on care quality and filling care gaps. Payer-oriented vendors also have kind of a focus on filling care gaps, but they're also very good at measuring costs and utilization. It was, personally, I'm kind of from the EHR world, and been sort of mostly kind of provider oriented. I've got a real provider lens myself. So when some of these payer-oriented vendors begin their PHM presentations talking about prior authorization, it's it's pretty clear we're kind of coming at this from a different kind of from a different perspective, but I do think it's possible to square the circle here. Both these payer-oriented vendors and the provider-oriented vendors are interested in moving to this idea of population-level health, helping care teams manage cohorts as much as they manage the health of individual patients. So we this on this page, we've got the names of every vendor that's in this report. Some of those vendors occur in more than one category here. The way to read this is to look at the EHR category on the left there, kind of on its own. Look at the payer category on the right on its own. And the middle three categories are essentially companies that don't necessarily, or that have a particular heritage or particular unusual set of skills in the particular categories they're in. The EHR vendors are obviously EHR vendors. I have to note that every single one of these EHR vendors has skills as a data aggregator or analytics vendor or a care management vendor. The reason we kind of segregated EHR vendors here is because from a provider standpoint, they are the system of record. They are the incumbent vendor. They are in pole position to provide all of this functionality. And they have probably grown. They have probably absorbed the lion's share or a big part of the growth in the last couple of years. But it's also important to recognize in every single instance, from the smallest EHR vendor there to the very biggest and meanest EHR vendor, that we have, we've talked to their customers who have not used them for one or more of these other categories. There are big hospital EHR vendors who are not able to pull together all the data that's needed for PHM programs. There are ambulatory EHR vendors who are not, for whatever reason, able to really pull together an effective care management program that can be distributed across a big network of primary and specialty care providers. The vendors in the far right there under the payer category are vendors who are either owned by a payer or have very extensive interactions with pure payer type organizations. So they've been able to put together, and some of those also have fairly significant provider organization customers as well. So this is just sort of the way that we kind of chopped up the world of vendors. I'm aware that people may have different opinions about who belongs in which category, and we're more than happy to discuss that. One of the things that I wanted to mention here is that these are not by no means are these kind of pure product types of engagements. We think that there's every one of the vendors that we had in that last slide offers some portfolio of services, and they really vary. And this slide has a kind of a listing of some of the kinds of services that are offered by these vendors. It's not an all-inclusive list. Many of these service engagements are customized to the specific circumstances of the specific customer. But we do think that the hospital-based customers are have been probably the biggest consumers of these kinds of services. But we do think that when you begin to look at the true independent ambulatory type networks, if an affordable service offering there could be successful. It just doesn't look like any vendor has really been able to put that together to date. So these were, in terms of the report, these are some of our major conclusions. There's a crying need for better inter-organizational process coordination and products that actually enable those processes. People talk about meds reconciliation and referrals and scheduling a lot. They've been talking about those two categories of functionality as long as I've been in healthcare IT. There are a whole host of other processes that nobody really talks about. The processes that unite hospitals and post-acute care, hospitals and various different community-based therapists who are running out there. So there's a tremendous opportunity for automating some very basic processes that occur among community participants. One of the things that all the providers that buy our reports complain about quality metrics and the reporting burden. This is obviously a big focus area for ONC, and the ongoing the ongoing tweaks to MIPS and MACRA is one of those, is to kind of reduce that reporting burden. As Brian Eastwood suggested, there aren't too many patients out there who've even heard the term population health management or PHM or value-based. That it seems like that should concern someone. Again, with the providers that buy our reports, we talk to them. In the end, it's the technology is sort of one thing, but deciding kind of roles and who gets to do what within their organization really ends up being the difficult part. From a functionality standpoint, we think that the ability to kind of model these contracts before a provider goes into them would be a welcome addition to any of these product suites. And so far, there hasn't really been too much action with respect to that. The ability to figure out how much it actually costs to achieve the goals in a population health management program is also, kind of a missing link here as well. So before we open the floor to questions, these are the things that we want you to kind of take away from our webinar here today. We think that value-based care, value-based payments are here to stay. There's no question that CMS and is kind of reorienting the carrots and the sticks, and we have to sort of wait and see how how that all plays out. Private payers are watching closely, and their interest in value-based contracts is only accelerating. Integration is a major technological opportunity here, area or obstacle, however you choose to look at it. There's more kinds of data that contribute to these PHM programs. There are more organizations that want to participate, and people want to see fewer applications for their end users and applications that really kind of do more. The analytics piece of this, we are moving beyond kind of reporting applications and beginning to see the ability for these products to actually kind of predict disease progression or likelihood to achieve quality, cost, or utilization metrics. So we're moving kind of beyond the kind of descriptive into the true predictive. As Matt told you, care plan content is really in its early days. And as Brian described, meaningful, including patients as a meaningful element in these programs is still something that is a bit of a work in progress. So at this point, I think we are going to take questions.
Okay, so we have our first question here. It is for Brian Murphy. Have you noticed a solution leveraging population health data in real time at the point of care? By that, I mean leveraging population health data plus analytics or machine learning to provide diagnostic or treatment guidance most relevant to the single patient being cared for at that moment. To this person's recollection, neither the EHRs nor the care management solutions that we listed offer the capability of real time at point of care.
Yeah, I mean, I guess, that was a long question. The short answer is all of those observations are essentially correct. I mean, I think the vast majority of these products are backward looking. They are based on data that in some cases is, a month old, 2 months, 3 months old. So yeah, and I think you're talking about the sort of the old-fashioned conception of clinical decision support and extending that to sort of include population health or population level kinds of interventions, as well as as well as individual interventions at the point of care. And I think we're pretty far from that at this point. We've got the other Brian, who's not on this call, Brian Eastwood, and Ken Kleinberg are working on a report right now that really talks about the application of AI and machine learning in analytics in particular. And this is a topic that I think that they will begin to get into, but the essential observation there is correct, that this is, we are not there yet.
Okay, the next question. Please discuss the integration of PHM solutions with continuous quality improvement processes, automation of A/B testing, or PDSA cycles.
There's a lot of stuff there. There's a continuous quality improvement, A/B testing, PDSA cycles. Frankly, I think it's fair to say that the products that we talk about in this report are all of the above. Everything in that question is mostly out of scope. The real gist of these products is on achieving better quality scores, managing cost, and managing utilization. And while all of those disciplines that you described could certainly, be incorporated in that, the kind of the data that's relied on and the functionality that's used to kind of pull together this data really doesn't include this kind of thing.
Okay, the next question is for Brian Eastwood. Have you found much integration between PHM solutions with patient experience metrics? Are organizations looking at the relationship between PHM programs and patient experience and retention?
The short answer is no, we haven't seen much of that. I so far have seen patient experience efforts and population health management efforts largely occurring in parallel. Patient experience is really focused a lot on the inpatient experience, on stemming problems at the point of care before a patient is discharged. That's typically the goal of those types of programs. And PHM has typically been focused a little bit more on delivering sort of self-management outside of the that sort of care experience. So I haven't seen too much integration there. It would certainly make sense to do that. And if anyone is aware of any sorts of integrations that do exist, I would be happy to hear a little bit more about those. So thank you for that question.
Okay, the next question will be split between Brian Eastwood and Brian Murphy. So I'll start with Brian Eastwood. What are the legal or data privacy related hurdles that one would face when designing a business strategy or technology solution to support the real patient journey?
That is a good question. I think what we would probably start with is really looking at the way to secure data both at rest and in transit for those types of sort of strategies or solutions, ensuring that whatever information a patient is sharing, that they have a very clear understanding of who is going to be using that data for what purpose, how it's going to be stored and secured, and expressing that to them in clear language. And also on the flip side of that, making sure that as additional data is being brought into a population health management solution that is coming from patients, that anyone on the clinical side is trained both technologically and also policy-wise in ensuring that that data is secured appropriately and used only for the purposes of sort of improving the care process for diagnosis, treatment, and so on. So it's really kind of a multifaceted sort of approach that involves both looking at securing data technologically, but also ensuring policy-wise that the members of the care team who might not have been exposed to this type of data before know what to do with it and how to treat it, in other words.
Yeah, I guess the only thing I would add is that I guess the only thing I would add is that there's HIPAA. There's 50 states worths of HIPAA out there. There are opt-in consent states. There are opt-out consent states. It's a very confusing set of circumstances for people who are in the business of understanding privacy, security, and consent. For patients to kind of explain this in some sort of coherent way to patients, I'm glad I don't have that job. And this is one of the issues that is causing the most concern for ONC with respect to this new trusted exchange framework, this new way to share data between different organizations. So it's a very complicated problem.
Okay, next question for Brian Murphy. Somebody was just asking about specifically TriZetto Cognizant as not being listed in our list of vendors reviewed, and they're wondering about our selection process for those vendors.
Yeah, so TriZetto and Cognizant actually are partners of several of the vendors that I showed on that slide. I didn't spend much time describing this, but I mean, there are 25 different vendors in this report. I think it's probably reasonable to believe that there could be as many as 100 companies that we could have included in this report. We've got inclusion criteria that I won't bother you with, and it wouldn't shock me to discover that TriZetto and Cognizant meet those. So we are always interested in talking to companies under really any circumstances. So if anybody who feels like they were unfairly left out, we'd love to hear from you. But yeah.
Okay, the next question is, how do you see value-based purchasing, bundled payments, ACOs, capitation, et cetera, being addressed on the revenue cycle side by the vendor community? So honestly, we actually have a report coming out about this shortly, specifically tied to the bundled payments. So I'll just put a plug in for that. That will be out in early May. But as far as this ties into PHM specifically, I'll let Brian answer the question.
That is not an area that we looked at in detail. I can tell you that the EHR vendors certainly had the opportunity to raise this as an issue, and it probably is for some folks, but The implications of PHM to keeping those billing systems running is not something that they seem to feel was a front and center kind of an issue, but it's certainly something that we should probably look at a little bit more closely.
Yeah, in general, we do perceive the next iteration of RCM solutions as being what handles these types of bundled payments and performance contracts. And that's really where a lot of innovation around contract management will be happening, and where we might see some early adoption of blockchain type technologies around smart contracts and things like that. So stay tuned for more research from us around that specific topic. It'll be much more focused than tangential coverage in this PHM report. All right, so our final question will be, post-discharge care management is a hard nut to crack. Can you say more about this and the strengths and weaknesses you see in this arena?
Matt, you there?
Yeah, sure. I'll take this question. I think it's a hard nut to crack for a couple of reasons. One, just the lack of IT infrastructure at a lot of post-acute facilities. Two, the microfragmentation of this market. You're starting to see more consolidation, but there's still a lot of mom and pop skilled nursing facilities and home health agencies, which are limited in terms of how much they can spend and have very limited IT infrastructure. And then I think third, there is a lot of issues with some of the payment methodologies that are ongoing with post-acute areas. There certainly is transition management programs that are in place that we're seeing as a part of these PHM solutions, and an emphasis on readmissions management. But in terms of the variability and the addition in terms of incorporating or giving access to post-acute facilities, that's not very common at all. And then in terms of the kind of line of sight issues, which is a huge issue in bundled payments, once the procedure or event occurs and the patient's discharged either to their home or to a post-acute facility, is still a real big issue. And that's something that I think is going to remain an issue and a challenge moving ahead forward. There are a couple of innovative companies who are trying to address this challenging area, as well as some of the more traditional skilled nursing vendors who are creating API-enabled structures and moving to a more web-based architecture. But I think this is going to remain an issue for years to come unless CMS does move ahead forward and radically change post-acute payment and set in place more of a kind of bundled payment or a per-patient payment system that'll track the patient across post-acute settings, which has been rambled about and MedPAC has looked into, but still there hasn't been enough effort to move that head forward. If that occurs, you'll see, I think, a real dynamic transformation in that area. Until then, I think it's going to be more piecemeal.
Okay, thank you, Matt. Thank you, Brian, and thank you, Brian, for taking the time this afternoon to guide us through this webinar and share some of your insights. So without further ado, we will wrap up this webinar. Thank you, everyone that attended and submitted questions. Please stay tuned for any notifications from myself with the webinar recording and slides. And feel free to submit any additional questions, as stated in that final slide, to brian@chilmarkresearch.com. Have a great rest of your week, everyone.